turn to my presentation. It's chronic migraine, and my focus will be introduction, pathophysiology, and clinical manifestations. Here you can see my potential conflicts of interest. Actually, I have none as regards this presentation because I will not talk about drugs. I apologize beforehand if there is any problem with my connection because I'm using my cell phone because I'm not in my place. So if it just the connection will be interrupted, just be patient and I will connect again. So what is chronic migraine? Chronic migraine is the term that the International Classification of Headache Disorders uses to describe a patient with frequent headaches, mostly migraine, believed to be biologically migrainous. From the historical point of view, the concept, the classification, and the names that we use for chronic migraine have evolved in the literature, especially in the last 2 decades. In the first classification, International Classification of Headache, there was not such a term as chronic migraine. But now we all use this term, chronic migraine, and the term chronic migraine has completely replaced earlier terminology such as chronic daily headache and transformed migraine. And this is important because it creates a lot of clarity in the field. So going through a little bit of history, you see here in 2004, the criteria of the second classification, international classification, introduced the idea of chronic migraine as a complication of migraine. And the diagnostic criteria was quite simply headache fulfilling criteria C and D for migraine without aura on at least 15 days per month for 3 months and not attributed to another disorder. So it could be classified, diagnosed in patient with migraine without aura on 15 or more days per month during the last 3 months, in the absence of medication overuse. But this definition was judged to be very restrictive because, as we will see when we are going to talk about the clinical presentations, chronic migraine may be a little bit different than episodic migraine. And so some patients who have chronic migraine, maybe they don't have 15 days of migraine, of actual migraine attacks over the month. So there was a revision of the criteria. And so you can see here the criteria, they became a little bit more complicated, but this was a necessary step. So in this case, the first criterion is headache, tension type, and or migraine on at least 15 days per month, occurring in a patient fulfilling criteria for migraine without aura, but in 8 of these days that were to be the criteria for migraine. So the patient has at least 2 of unilateral location, pulsating quality, moderate or severe pain intensity, pain aggravated by activity, and nausea and or vomiting, and photophobia and phonophobia. Also, it was introduced the idea that a diagnostic criterion could be the response to specific acute treatment of migraine, such as triptans or ergot. So basically, these were the 3 pillars of the new classification: headaches on more than 15 days per month for at least 3 months, migraine features, migraine diagnosis on at least 8 of these monthly headache days, and no medication overuse. Now we have the third classification, international classification of headache. It was preceded by the beta form, and then it ended up with the final form in 2018. And we have chronic migraine. Chronic migraine, in this case, is a standing alone subchapter of the group of migraine. You can see 1.3. And it is no longer part of the complications of migraine. And here you can see the final criteria. We have headache, tension type, and or migraine-like on at least 15 days. So this was kept for at least 3 months. Criterion B, and here there is a novelty, because you see that it occurs in a patient who has at least 5 attacks fulfilling criteria for migraine without aura, or fulfilling criteria for migraine with aura. So there is also chronic migraine evolving from migraine with aura. Criterion C kept the idea that on at least 8 days, this type of headache should have migraine features. So criteria C and D for 1.1 migraine without aura, criteria B and C for 1.1 migraine with aura. And again, which is also important, it is believed by the patient to be migraine at onset, or it is relieved by a triptan or an ergot derivative. Criterion D, of course, is not better accounted by another diagnosis. And here is just criterion 1.1 for migraine without aura. And on the lower part, you can see the criteria B and C for migraine with aura. So once we have defined the criteria, the diagnostic criteria and the classification of chronic migraine, what are we talking about? Are we talking about something that is very rare? No. We are talking about a disease that in the general population affects from 0 to 5.1% of people. There is, you see, quite a wide variation, and this is probably is reflecting some leftover of the different definitions, but probably there are also differences among populations. The prevalence of chronic migraine, we know that it can be present during the adolescence, but it increases throughout the adolescence, and it peaks in midlife and then declines after the age of 50. But the highest prevalence you can see from the picture, it is in the ages 40, 49, in both sexes, but you can see that chronic migraine is more prevalent in women. Like migraine, also chronic migraine has a preference for women. So if we enter now in the clinical aspect, what we see usually in our patient, we see patient with episodic headache, usually an episodic migraine, 70–80% of the population reported in the study, in the literature, it happens like that. And the chronification is usually a gradual, sometimes over decades. And of course, there are different factors. We are going to see them a little bit later during this presentation. But of course, there are risk factors for the evolution from episodic to chronic migraine. One, and probably the most important, is the increased frequency of migraine attacks, so an increased severity of the disease. Then there is a genetic susceptibility, and also an important factor is played by risk factors and comorbidity. And basically, we know that risk factors may be very important, and they have been classified into two groups, modifiable and non-modifiable. So on the non-modifiables, there is not much that we can do, but on the modifiable, there definitely is something that we can do. So this is what usually we see that happens in our patient. If we dig deep and we ask them, they will tell, yes, it started maybe during the adolescence or during the primary school, and there were occasional attacks. Maybe they were not so intense. Then over the years, the frequency of attacks increased. The duration of attacks tended to increase. The response to acute medication tended to become less strong. It attenuated or it went away. And then after a while, as I said, years or decades, you can find this situation when, and you can see that in the lower part of the slides, where there is a background headache. Some patients, they tell me, my head is never free. I always have something. And on this background headache that can be of low intensity, maybe 2, 3, 4 on an NRS scale, there are the actual attacks. And here is another way to see the evolution. And what I'm telling you is about chronic migraine, but it could be the same also for tension type headache. you have a patient with an episodic disease, isolated attacks, then there is a tendency of these attacks to become maybe more close to one another. And in between them, the patient does not recover the complete wellness, the complete well-being, but there is always a background of disturbance, of background of annoyance, a background of headache. So you see there is episodic migraine, there is a threshold when something starts to change, there is a migraine transformation, and then you get to chronic migraine. And I said the factors, I spoke about the factors, and of course there are some factors that have been identified. Here I'm reporting a study by Zaza Katsarava. It's quite old, but it's still one of the most important that we have to analyze the chronification, the process of chronification from episodic migraine to chronic migraine. And you can see that I have circled in red the most important factor, the most strong factors that are involved in the chronification. Headache frequency from 5 to 9 days per month. And it seems Laplacian, but it is not. Headache medication overuse, and so intake of acute headache medication on at least 10 days per month. That is a threshold that really should be used as a red flag to be more aggressive on that patient, because that patient is at high risk to become chronic. And then again, headache frequency, when it increases and it goes above 10, so between 10 and 4 days per month. You can see that the diamond is close to 25 times the increased risk of an episodic migraine to become chronic when these conditions are present. And I mentioned before the factors that can be non-modifiable. Female sex, well, to a certain extent it is modifiable, but let it sit in the non-modifiable factors. Older age, definitely we cannot modify that one. Low educational level, maybe we could do something there with awareness activities. Low income, genetic factors, Caucasian ethnicity. And then there are the modifiable factors. High frequency of attacks, so episodic migraine. So let's be more aggressive when we treat patients with episodic migraine. Let's not wait, it becomes chronic. Anxiety, depression, so this type of comorbidity. Stressful life events are risk factors for chronic migraine. And of course, in some cases, they are not modifiable, but they can be managed at least. Obesity, heavy caffeine intake, tobacco use, overuse of acute medication for the treatment of migraine. So going back again from episodic to chronic migraine, what do we see in the everyday practice in my headache centers and probably in your practice? We see a patient with an episodic migraine, and this patient is taking care of episodic migraine with acute medications. And over time, these acute medications start to fail. The frequency of the headache, of course, is increasing because you don't have the possibility to stop the attack. So instead of lasting 2-3 hours, it lasts 2-3 days. So the number of days increases. And so we end up in, as I said, weeks, years, sometimes decades, with a chronic headache that is present at more than 10 days per month. And it is a chronic headache that is less responsive to treatment. So the patients start to say, okay, I could live with this if it only lasted 1 or 2 hours and if it responded to acute medication, but the acute medication are not helping me. So basically my days is spent trying to deal with this nasty pain. What also happens is sensitization, but we will see this later when we talk about pathophysiology. And so we have a bunch of people, which can be quite large. Every year we hospitalize more than 400 patients with chronic migraine and medication overuse, and we see more than 2,000 patients with chronic migraine. So 77% of them evolve from an episodic migraine. They are mostly women. There are also some men, but they are mostly women, mostly young women with a family, a job, a lot of activity to keep going. And so during the active phases of life. So as my colleague before was talking about, it is a functional disease. There is nothing wrong in the brain of this patient if we go and evaluate them with a normal MRI. There is nothing wrong if we go and open the brain, but nonetheless, these patients are highly disabled. So it's one of the most disabling disease. And what we see with our patients is sometimes they can have different lifetime trajectories. So there are patients that I call the blue line, the remitting. They start as an episodic migraine, they go for a period into chronic migraine, so they have an increase in the frequency of headache, but then there is a remission due to the appropriate treatment, due to the changes in life, due to many things, but these are the good ones. There are patients who suffer from episodic migraine and they remain stable across their life. There are patients that I call them fluctuating because they have some relatively good periods when they are not chronic, so they don't have more than 15 days per month. And then there are bad periods lasting weeks, months, years when they are chronic, and sometimes they go up to 30 days of headache per month. And then there are the patients who are progressing. They start again as episodic migraine, and over time, sometimes because they do not look for help, appropriate help with the right specialist. Sometimes because no matter what you do, this patient, they do not respond to anything. We have, it's the type of patient we call refractory migraine. They fail. It's not that they fail, it's the drug that fails them. Each type of drug fails them, and so there is nothing that seems to interrupt this very strongly progressive type of disease. And I'm showing you an example. This is one of my patients. She was 47 years old when I saw her. And of course, typically, her migraine onset was during the adolescence when she was 11 years old. And you can see across a lifetime what happened to her. And the blue line represents the number of headache days per month. So over 2-3 decades, she became chronic. And particularly, this started when she was 23, because she started to work, then she married, so her life changed completely. And she experienced a progressive worsening, a progressive ineffectiveness of acute medication, and the increased use of acute medication. At 35 years old, she was chronic at that point, because you see that she passed the 15 days per month threshold. And at that point, she had already tried flunarizine, but that didn't work much and increased her body weight of 5 kilograms. She had tried amitriptyline for 2 months and she put up 4 more kilograms. Topiramate, it was completely ineffective, and it also induced sedation, side effects that she could not tolerate. She went over multiple detoxification from acute medication. They worked, they were effective for maybe at least 2-3 months, but then she went back to the same pattern. She tried onabotulinum toxin A. She had a minimal improvement in the sense of a very small reduction of headache days per month, and also a very small reduction in the intensity of the attacks. No wonder that, of course, this patient, she developed depression. And the response to acute medication was only partial. And this was the diary. This is the headache diary that we use in Pavia Center. You can see in vertical the days, and in horizontal on the axis, you can see the hours of the days. The dark blue means very intense pain. The patient is not able to do anything but lying in bed. And then you have the 2 types of shaded areas, and one represents moderate pain. The patient is able to do something, but not the most requiring activity, the most requiring tasks like working or studying. Or you have the lieve, mild intensity. The patient says that the head is not free from pain, but he or she can function normally. You can see that this patient, she had only 4 days who were headache-free over a month. She had a lot of blue, which means that she was bound to stay in bed. And if you look in the lower part, you can see the number of acute medication that she took. Every day she took at least 1, in some cases 2. In one case, she took 3. She had to do something very important that day, so she just took pill, just to be able to stand up and walk and do something over life. So this is why it's very disabling. This I show to you because it's a type of patient that it happens to me, and it has a name in the United States. It is called the roller coaster subtype. So the patient who fluctuates a lot, so they move from being episodic migraine to being chronic migraine. And whatever it is, the roller coaster or the patient with the chronic migraine, like the one that I showed you before, what we know is that chronic migraine, even when it fluctuates between being chronic migraine or high frequency migraine, it is associated to high disability. This is a study that I'm showing from the Spanish group of Torre Ferrus and Patricia Pozorosic, and you can see on the left the disability represented by the MIDA score, and you can see that the patient with the severe disability, the light blue, are a relatively small percentage, 25% in the case of low frequency episodic migraine, LFEM. The disability, the severe disability increases to almost 50% of the patient with high frequency migraine, and it touches 60% of the patient with chronic migraine. The same picture we have if we use IT6. It's a scale that it's informative about the impact of migraine on everyday life. And you can see, again, if we just focus on the patient with severe impact, we can see that already an important percentage of patients with a low frequency migraine, they report severe impact in their life because of migraine. But you can see that if we move to the right, high frequency migraine and chronic migraine, the impact is severe in the majority of the patient. And as you can see, there is not so much difference between high frequency migraine and chronic migraine. I'm going to talk to you about the pathophysiology. I'm going to skip all the discussion about the pathophysiology of episodic migraine because probably we won't have time to go through it. Just what it is that we know for sure that is happening in episodic migraine is that we have the neurogenic inflammation taking place in the meninges, because you know that the brain does not have nociceptors. So we feel pain in the head area because there is an activation of the trigeminovascular system in the meninges. And this trigeminovascular system is releasing vasoactive neuropeptides that induce vasodilation, that releases substances that induce the activation of, for instance, you can see here the mast cells. So we have there calcitonin gene-related peptide, we have substance P, we have bradykinin, we have nitric oxide, and all this is this activation of the trigeminovascular system here is relied back then to the center, to the nucleus trigeminalis caudalis, where we have the second order neuron. And then it is processed in the thalamus, and ultimately it reaches the cerebral cortex, where and when we feel the pain, we feel that something is going bad in our day. So we know that vasoactive neuropeptides are important. In particular, you know, all of you know about calcitonin gene-related peptide now, and calcitonin gene-related peptide concentration were reportedly higher in patients with chronic migraine than those in episodic migraine. And so there are some study groups that are suggesting to use CGRP as a potential biomarker of chronic migraine. But let me say that the mechanisms that are basically subserving the transformation from episodic to chronic migraine are not fully understood. But we know that they are likely multifactorial and they involve more than one level of the CNS. So I just show you the periphery, the meninges, but you have seen that there are many stations along the circuit, as there are the ascending circuit. Excuse me 1 second, that my dog is giving me a hard time, sorry. Okay, sorry. So unless you wanted to hear me barking along with my dog, I had to let her out. So we know that there are different processes at play here. Atypical pain processing, central sensitization, cortical hyperexcitability, and of course we have seen neurogenic inflammation. All of them, they probably play a role in the transformation. We know so that the entire picture can be, in a simplified vision, seen like this. There are risk factors. We have seen some of them: female sex, depression, stressful life events, genetic predisposition, obesity. And there is an evolution from decreased threshold for generation of migraine attacks. So it starts as episodic migraine, low frequency migraine. Then there is an increase in
Professor Tassorelli, are you with us? I think we have some technical problems. We will wait for Professor Tassorelli a little bit. Okay.
I am back. Sorry, I knew this was going to happen. This was not my dog's fault. It is just a bad connection. Sorry. So I will restart from where I left.
Thanks.
And so, as I was saying, how can migraine become chronic? This is another way to see a little bit more complex. I'm starting from something that is more simple, but it's not simple what we are talking about. So we have predisposing factors, we have precipitating factors, we have perpetuating factors. And so we have triggers, we had accident in our life, we have menopause, stress, disease. And so we have an episodic migraine that evolves to a more aggressive type of migraine. Maybe there are also sleep problems. I mentioned psychological comorbidities, but sleep is also very important. And maybe there is a not perfect use of caffeine, because too much caffeine, then we stop caffeine, there is a rebound headache. And of course, there is the problem of medication overuse, that we are going to dedicate a few slides to that. Weight gain, obesity is another problem, muscle tension, and we end up with a patient with chronic migraine. So I mentioned sensitization. Sensitization is important in episodic migraine, but it is also important in chronic migraine, because we know that there are two neurons, peripheral and center neuron, in a very simplified vision of pain transmission. And we know this in the perivascular areas of the meninges is going to activate the peripheral neurons, which is sensitized. And so these neurons releases neurotransmitters that activate the central neuron. This is what happens in episodic migraine. But in chronic migraine, what we have, or in repeated episodic migraine, we have that the peripheral sensitization, so the repeated peripheral sensitization is leading to central sensitization. And so what happens is that maybe when the peripheral neurons is not stimulated by the neurogenic inflammation in the meninges, there is always some type of activity going on in the central neuron. So the system, the engine of migraine, actually in some patients starts to never be stopped. It's always turned on. And this is a problem, because in this case, it's more easy that an attack takes place and it becomes devastating. Another actor of the chronification of migraine can be identified in the descending central pain control system. We know that There are, I mentioned the ascending part of the brain process of the brain messages, but we know that there is also descending control of pain. And one is good. I've identified here in green is the cingulate cortex, is the amygdala, is the periaqueductal gray, it is the dorsolateral pontine tegmentus, is the ventromedial rostral bulbar area. Here we have opiates, we have GABA, we have noradrenaline, we have serotonin, and this neurotransmitter, they reduce the pain. But on the left side, we have another area in the bulbar area, the ventromedial rostral part of the medulla. And here, the neurotransmitters that are released are glutamate, aspartate, and again, serotonin. And in this case, this neurotransmitter, they can act as facilitators of the pain. So you can see that serotonin can both attenuate the pain or increase the pain. And so one of the hypotheses is that there is definitely a reduction of central pain control. For instance, some authors have suggestions that there is some sort of subclinical hypoxia during migraine attacks, and this is leading to abnormal deposition of iron. And iron catalyzed the free radical injury in the brain. Or another hypothesis, and of course here we are more in the field of the hypothesis than in the evidence-based, hypofunction of lateral descending pain modulatory circuits, the decreased activation of some nucleus, in particular the nucleus cuneiforms, which accounts for descending facilitation of nociception or impairment of descending inhibition pathways. So you see that the picture starts to get more and more complex. But just to summarize, we mentioned about the peripheral mechanism, external triggers evokes activation of trigeminal-vascular afferents, which terminate in the lower brainstem, the nucleus trigeminalis caudalis. But then there are other mechanisms then that enter in play. There is an increased tone of ascending pathways inhibited, or decreased tones of ascending pathways. And so in one case, if there is an increased tone in ascending pathways and this is inhibited, we have no migraine. If there is a decreased tone in ascending pathway and excited, we have migraine. So it is a quite complex situation. And I try to make it simple, but it's difficult because actually we need to be, if we want to be faithful to what we know that is happening in the brain, in the periphery during chronic migraine, you see that the picture is definitely bigger, because on the left we have the risk factor, we are familiar with them. Then you see that in the center there is the top-down modulation, the cortex. I will not show you the data that we have on the cortex, but there are a lot of functional neuroimaging and neurophysiology data that shows that the cortex of the patient with chronic migraine is not functioning in the same way as the patient with the healthy control or the patient with episodic migraine. So there is the cortex, there is the limbic system, the insula, the hypothalamus, the hippocampus, the amygdala, and more that are involved. Of course, there is the brainstem, the periaqueductal gray. And you see that on the right, there is this trigeminal nociceptive pathway where we have the trigeminal vascular input, the spinal trigeminal nucleus, the thalamus, and the sensory cortex. All this is acting together. When everything is acting perfectly, we have a healthy person. When something is not acting perfectly, maybe we have a patient with episodic migraine. When something is definitely wrong, we have a patient with chronic migraine. And let me tell you a few words about acute medication overuse, because we know that the risk of developing chronic migraine depends also on the frequency with which abortive drugs are used and the type of drug used. Too much use of acute medication may lead to medication overuse headache, a condition that is characterized by chronic headache and overuse of different acute medication. So the definition of the International Classification of Headache, of medication overuse, is a headache occurring on at least 15 days per month for at least 3 months. And this is developing as a consequence of regular use, overuse of acute or symptomatic headache medication on 10 or more or 15 or more days per month, depending on the medication, non-steroid anti-inflammatory drugs or triptans, for more than 3 months. It usually, but not invariably, resolves after the overuse is stopped. And what do we have to do with this patient? We have to give the two diagnoses, because most of the patients with medication overuse headache, they are also patients qualifying for the criteria for chronic migraine. So we have to use both diagnoses, chronic migraine and medication overuse headache. And we know that we don't know much about what is really happening when the patient overuse acute medication, but we have some pretty good insights from basic studies. For instance, this is a study that was published more than 10 years ago by Milena De Felice. She was working with Frank Porreca at that time, and in the animal, she administered to this animal sumatriptan for several days, and she went to evaluate the periorbital withdrawal threshold. So she went to evaluate the trigeminal activity in the rat exposed to the sumatriptan. And as you can see, over the days, there was a decrease in the threshold of response to the periorbital stimulation. So this means that this animal exposed to sumatriptan had a nociceptive system that was deranged with a lower nociceptive threshold. And we have more recent data from other groups that were published in Brain a few years ago, showing that you expose animals to the chronic treatment with, you can see that name LY344864 is lasmiditan, is another drug that has been already marketed for the acute treatment of migraine in the United States. It will probably arrive soon also in Europe. And you can see that you expose chronically the animal to lasmiditan, and what you see, there is an increased expression of calcitonin-related peptide in the caudal trigeminal nucleus. We have more data of this sort. In this case, again, animals were exposed chronically to sumatriptan and lasmiditan, and you can see that, again, we see that in both cases there is a decrease in the periorbital mechanical threshold, but there is also something else, because they become more sensitive to bright light stress, which is the same symptom that our patient endure, and they also have a reduction of the threshold when they are exposed to nitric oxide. So these three conditions, they are experimental conditions, but they clearly mimic allodynia and latent sensitization, which is what we see in our patients every day. 2 slides on the endocannabinoid system. So you might probably know that we have been working a lot in my laboratory, but not only our group, also other groups have been working on the endocannabinoid system. The endocannabinoid systems is very important for the maintenance of the homeostasis of our body. It is not only important for the brain, for other organs of our body. I'm showing you this complicated slide just for you to focus on 2 names that I'm going to use in the next slide, because you can see that basically we have the main endocannabinoids are represented by anandamide on the left and 2-acyl glycerol, 2-AG, on the right. And 2-AG, for instance, is synthesized using this enzyme that is called the DAGL. And then it is degraded using this enzyme that is called MAGL, because endocannabinoids, they are not stored in the vesicles. They are synthesized on demand. There is a need for them, and you have DAGL acting to produce 2-acyl glycerol, and then they are removed. So MAGL is active there to remove the unnecessary 2-AG. And we have evaluated these 2 enzymes, DAGL and MAGL, in patients with episodic migraine, chronic migraine. And you can see here that there is a spectrum. So you can see that, for instance, the DAGL, let's start with DAGL, the enzyme that is synthesizing the endocannabinoid. You can see that it is much more increased as compared to control, but also increased as compared to episodic migraine in the patient with chronic migraine. Then we detoxify the patient and look what happens. There is a decrease of the enzyme. If you look on the left is the DAGL, the MAGL, again, we have the more or less the specular picture. So there is a much more marked increase in chronic migraine medication overuse, and this goes down after the detoxification. It means that this system is hyperactive. The system is creating more endocannabinoid, and then it is destroying this additional cannabinoid that is produced. So another concept, and this will be the last concept that I'm giving you today, is about the allostatic load, because we have mentioned genetics. I did not mention what we have about genetics because it is an entirely different argument, but we have some data about the importance of some genes in medication overuse headache. We have epigenetic modulation. When we talk about stress, of course, we are talking about epigenetic modulation. Then there are, of course, comorbidities and gene dysfunction, but we also have the two possibilities. There is an increased allostatic load or a decreased allostatic load. And the allostatic load is defined as the cost of chronic exposure to elevated or fluctuating neural responses resulting from chronic or repeated challenges. And so you have a decrease in allostatic load. And in that case, you have a patient with a stable episodic migraine or with an episodic migraine that is resolving over years. On the other side, you have the patient with an increasing allostatic load, and in that case, you may end up with migraine chronification. At that point, I gave you some information. Diagnosis is quite easy. There are the criteria of the classification. Of course, it is important to collect an adequate, a careful, a thorough headache history. This is the first step, and it is very important to rule out secondary headaches. So always be aware of the red flags, because it may be chronic migraine, it may be chronic migraine medication overuse headache, but it could also be something else. So be sure that you have collected an accurate headache history and you have performed a neurological examination. And here I'm listing the red flags, but probably you are aware of all of them. So I think I've used the time that I had. I'm going to close with this: stop the insanity. Stop the insanity, maybe not only in our field in chronic migraine, because there are other types of insanity we have been living in the last 2 or 3 years, but those are more difficult. Chronic migraine maybe is more simple to tackle. It's more simple to just to prevent it to become chronic migraine. We have the possibility to do that. So this is my last figure I'm showing. I gave you a lot of information. I hope it was not too much. You probably have questions. I'm here to answer your question. Thank you.